we move to the next topic, ventilation management during VV and VA. So our focus will be just to recall the ecmophysiology and benefits and harm of the mechanical ventilation. What are the settings we look for? What are the basic evidences we have, not in much in the detail, and what monitoring, how we monitor this, and what are the future prospects. So if we talk about the lung injury, for which most of the time VV ECMO is required, or any disease condition which leads to an inflammatory process and it causes inflammation and biotrauma, and ultimately it leads to a reduced lung compliance. And once the lung compliance is reduced and patient is struggling on mechanical ventilation, patient's self-inflicted lung injury itself add on to this, and all these contribute to the barotrauma, volutrauma, epileptotrauma, and ergotrauma. This is further added by the ventilator-induced lung injury because besides the patient's own injury. So it can be direct and indirect, and this vicious cycle goes, this further induces more inflammation, and this further reduces the lung compliance. So this is what exactly happens when we place a patient on ventilator who has developed ARDS. So if we look at that, how the ventilation across the world is being planned when a patient is on ECMO. This was the survey which was published in 2015 by ELSO. It shows that there is a consensus that everyone wants that there should be a lung protective ventilation strategy, but there is a significant variation in the practices. Somebody is using a pressure control, somebody is using a volume control, somebody is restricting to a 5 ml of tidal volume, somebody is doing a 6 ml tidal volume. But yes, higher P was associated with the better outcome in all these conditions. But simultaneously, we should remember that there are several systemic effects of the mechanical ventilation and which can be harmed. The most important thing was the positive pressure ventilation starts. And especially when the lung compliance are poor, it leads to a decreased venous return because the right side of the heart is relatively thinner. And this reduction in the venous return reduces the cardiac output. And this pressure increases the central venous pressure, and reduced cardiac output leads to a decreased blood pressure. And we need to support with the fluid, which further worsen the lung condition. And this decreases the lymphatic flow as well. So there is a fluid accumulation in the lung, and this further worsens the gas exchange. There is an altered surfactant, which decreases the compliance, induces the inflammation, and alters the immune defense mechanism. Moreover, giving oxygen, it produces the tracheobronchitis, absorptive epilepticus, hypercarbia, and diffuse alveolar damage. And we are well aware of the organ dependence, that organ crosstalk, that once there is an effect on the lungs or heart, it is going to affect the kidney and other organs as well. So this, whenever we are ventilating our patient, we should always try to make a balance so that we can minimize the risk of these deleterious effects. So we can understand with this what exactly happens when there is a decreased systemic venous resistance, RV inflow is decreasing, pulmonary venous resistance is decreasing, and ultimately the LV ventricular filling is compromised, and that decreases the LV compliance. And you can see that in this diagram that there is a acute RV decompression, and there is a shift of the septum towards the LV. That D sign we can see the D-shaped left ventricle, because these two ventricles share the common fibers, septum and the common pericardium, and the ventricular are there in the interdependence. So this all happens with the positive pressure ventilation, especially in a patient with ARDS. So barotrauma and volutrauma, if you say technically, more or less effect remains the same, because once you are pushing the volume, and there is, because of heterogeneous nature of the ARDS, there is an increase of the transpulmonary pressure. It induces the injury. So this is why we try to restrict the plateau rate
class
can we mute ourselves?
conference.
Um, so plateau pressure is restricted less than 30, and this is what we look for, that we are reducing the ventilating tidal volume less than 6 ml per kilogram of body weight. Moreover, the anti-lifter trauma, because what happens, there is a end expiratory low or negative end expiratory transpulmonary pressure, which is, there is a cyclical opening and closing of the alveoli, and that further enhances the injury. And PEEP is always useful in preventing that trauma and worsen the further injury. And mechanical activation, that again creates a biological reaction, and biotrauma with the because of the oxygen itself is known for the ventilator associated lung injury. So what we want, why we are thinking about changing the ventilatory concept when we are initiating the act. So we understand that the conventional ventilation is not sufficient, and that is the reason that the patient is requiring ECMO support. And the timing can be anything, can be just initiation of the ventilation, or it can be 3 days after the ventilation or 4 days, depending upon the several factors. But the most important factor is the severity of the disease process. Because if the hypoxemia is severe, in spite of high P, then possibly he becomes a candidate early for supporting with the VPM. And moreover, if there is an uncompensated hypercapnia, that the pH has gone below less than 7.2, then possibly an early ECMO institution can be useful. So whenever we initiate ECMO, at that time, we all know that the ventilatory settings are too high. PEEP is very high. Peak pressure is crossing beyond 40, and plateau pressure is, we are trying to restrict, but at the cost of increasing the PaCO2 level, because we are reducing the tidal volume to prevent all barotrauma and volume trauma. So, but one should remember that the mechanical ventilation duration with the high ventilatory setting should not be too long, because if it is going beyond 7 days, then the permanent fibrotic changes which starts occurring in the lung, probably he may not be the candidate for recovery so many times. But during the COVID, what we have seen that even after 10 days also, these patients has recovered very well. So, but one thing is understandable that this research has proven that early initiation of ECMO, if the patient has developed serious ARDS, they are associated with a better outcome, especially in the population of the trauma patient. So our goal is always to restrict the transpulmonary pressure less than 25 or plateau pressure less than 25, so that we can minimize the risk of pulmonary injury further. So what should be our ventilatory setting? Whether it should be same or it should be different during the VA and ECMO. So let's start understand the physiology. We know that in VV-ECMO, the circulation is still in the series with the native circulation. So there is no change. You are just taking the blood from the venous system and pushing the blood in the venous system, the oxygenated blood in the venous system, which is passing through the pulmonary circulation, mixing after mixing, and depending upon the lung condition, that how much gas exchange is taking place in the lung, it is reaching to the systemic circulation. Basically the ECMO is replacing all our part of the lung function. So there is no change. You are just adding oxygen to actually circulation by taking some. But if you look at the VA ECMO, your circulation is the parallel with the native circulation. So you are replacing all our part of both heart and lung. So that you should always keep in mind that in most of the time, your lungs are not bad. There is an adequate ventilation. You are putting these patients on VA because of the cardiac issue. So gas exchange, how this gas exchange takes place during the VV-ECMO, let's see one by one. The extent of non-pulmonary gas exchange required during ECMO is directly related to the limitation of the pulmonary gas exchange. Then how much you want? The amount of oxygen supplied to the patient by ECMO circuit is limited by the maximum oxygen delivery of the membrane. So it all depends on how much ECMO flow you are, how much FiO2. Most of the time when we initiate ECMO, you are keeping 1. But the total oxygen delivery will depends upon the how much ECMO fluid that is associated with several other factors like how much is the cardiac output of the patient, whether patient is having the hyperdynamic circulatory state, then possibly a lower saturation will be there in spite of good flows because it will not match with the cardiac output. The if you talk about the current generation ECMO oxygenators, they deliver almost 450 ml of oxygen per minute. So it depends on the rate of the blood flow, the hemoglobin concentration, and how much saturation we have in uh, these the hemoglobin. And VV ECMO, the circuit flow is related to both to the inflow cannula diameter and the cardiac output. So you can't achieve, if suppose you have placed a very small cannula as an access cannula, then there is a problem that you will not be achieve that flow which is required depending upon the patient's cardiac. Higher sweep gas flow, this will help you to wash out the carbon dioxide. So you can control the carbon dioxide by changing the sweep gas flow. So what setting we look for whenever we talk about ventilation? It's a mode, FiO2, tidal volume, ventilated rate, and P. So what should be our mode? The choice of the mode, there is no hard and fast mode. So ELSO recommends that the use of the pressure control mode can be helpful, but the choice depends upon your local resource availability as well as your experience that which mode you are more comfortable. Your purpose is to reduce the lung injury by restricting the plateau pressure or more precisely the driving pressure. So different mode has not been compared during ECMO run. Assist control mode in the pressure or volume mode should be done in the initial phases of ARDS during the ECMO. Pressure controls modes appear to be adequate and is probably the most popular mode. If you look at the research, it is the most popular mode in the initial phase of ARDS management. However, as per the ARDS state protocol, it's the assist control volume mode which has been run. APRV might be an alternative mode as to the conventional pressure control mode during an ECMO, but still there is no research which shows that APRV has shown any survival benefit. FiO2, whenever you start, your target is to keep arterial saturation more than 85%. You do not reduce ventilator FiO2 very quickly, but you try to bring it down as low as possible. And also recommends 0.3 to 0.4, 0.4 of FiO2 once the patient has been stabilized. The tidal volume, it is recommended that during an ECMO run, it should be less than 4, but whenever a patient is in the severe ARDS and when you restrict your plateau pressure less than 25 and your driving pressure around 40, then with the severe ARDS, how hardly patient develops 30 or 40 ml of tidal volume. And often this is called as ultra-protective lung ventilation to prevent further injury to the lung. But because the issue with this ultra-protective lung ventilation is that your patient might retain the carbon dioxide, which you can easily manage with the use of ECMO, that you can increase the sweep gas flow and you can wash out the carbon dioxide in these situations. But you should remember the complication of hypercapnia as well as rapidly reducing the carbon dioxide. Hypercapnia itself can increase the intracranial pressure, can lead to pulmonary hypertension or even affect the myocardium and decreases the renal blood. However, a rapid reduction of the carbon dioxide may lead to an intracranial hemorrhage. The rate, the various studies have recommended, but usually a lower rate is preferred in most of the study, ranging from 4 to 30 people have recommended, but most of the study recommend rate around 10, 4 to 10 breaths per minute. Again, P probably one of the most controversial and most important component which helps for the recruitment as well as for keeping the alveoli open during the expiratory phase. So when you reduce the tidal volume less than 4, there is a more risk of atelectasis and more chances of VQ mismatch. So higher level, which maintains the convective ventilation and decreases the turbulent flow to the alveoli, especially those which are damaged, can help to prevent further damage to the lung. However, we should keep in mind that the higher peak level can affect the hemodynamics significantly by reducing the venous return. You should look for the frequent echocardiography to ensure that there is no um, right ventricular dysfunction when a patient is on VV-ECMO, which is very common once the VV-ECMO is prolonged. So here, this study has shown that the reduction of the tidal volume to 6 ml per kg has significantly um, improves the patient outcome. This is another study which shows that there is a increased um, improvement, no patient-related complication, even when you are in the extracorporeal carbon dioxide removal group or the non-group, there is no difference in the outcome-wise. So coming on the VA, when we talk about the strategy during the VBA, we try to limit the alveolar restraint by keeping the um, plateau pressure less than 25, by keeping a tidal volume less than 4 ml per kg, and we limit the respiratory rate. So we prevent the alveolar restraint. We limit the atrial trauma by keeping a higher P, and we limit the reabsorption atrial acceleration by decreasing the ventilatory FiO2 and maintaining the adequate. And we avoid any over distension because of the heterogeneous nature of the disease. So we keep monitoring the transpulmonary pressure. But this is what you can see. When we are trying to restrict the pressure, you can see the tidal volume is in the range of almost 20. And here you can see the patient saturation was just 85 with the ECMO flow, hardly any contribution by the ventilator. And you can see the compliance, how poor the compliance is for this particular patient. So if you look at the study, various studies, that what is the recommendations? So as per the ELSO guideline, it is reasonable to have the deaccelerated flow like a pressure control with a modest PEEP and keeping a rate around 4 to 5 breaths per minute. However, the European Network of Mechanical Ventilation, they again recommend a PEEP more than 10 with the tidal volume to restricting a plateau pressure less than 25 and rate is around 6 to 20, keeping a FiO2 in range of 30 to 50. Whereas similar things were there in the CESAR trial and EOLIA trial, where in the CESAR we had restricted the inspiratory pressure less than 25 and keeping a PEEP in the range of 10 to 15 and rate around 10 with the FiO2 as low as 30%. So more or less, there is a consensus that as a lung protective ventilation with a higher PEEP keeping a low rate and as low FiO2 as possible. So this is the approach how we should go for whenever we are doing a ventilation in a patient with the ARDS who is on. So we look for a pressure control mode. We try to restrict the peak inspiratory pressure less than 35, keeping a tidal volume less than 8, and we try to reduce as low as possible to less than 6, keeping FiO2 less than 0.6, and optimizing PEEP ranging from 10 to 80, keeping a higher respiratory rate so that we can wash out carbon dioxide. We keep these patients sedated and paralyzed, and our target to ensure a mean arterial pressure 70 to 90, and we target a saturation around 90% with a PaO2 more than 60, and keeping a PaCO2 less than 60. We accept some hypercapnia in these patients as a lung protective strategy. Right? If there is a poor response to the mechanical ventilation alone, and there is a PaO2 of 5 to less than 70, or PaCO2 is again rising above 60, or there's a pneumothorax with a significant leak, then possibly we have to ensure that we are supporting this patient with a VVM. So in the initial settings, we keep a gas FiO2, ECMO FiO2 1. We maintain an optimal gas and blood flow so that we are targeting a saturation above 85. And we look at the post-oxygenator PO2, it should always be above 200. And we try to provide a lung protective mechanical ventilation, switching over to the pressure control, restricting a peak inspiratory pressure less than 30, plateau pressure less than 25, and um, our driving pressure less than 40. We keep a higher P. We try to reduce the FiO2, though we look for a saturation, not in too much hurry, and we keep the rate around 10. It's better to remember the rule of 10, that your respiratory rate is 10, your respiratory pressure is 10, and your PEEP is 10, so that you are restricting your delta, your plateau pressure less than 25. So our therapeutic goal is always keeping a SpO2 around 90 with a pH above 7.2. So once the patient has improved, we start reducing the ECMO flow and we start reducing the ECMO gas flow FiO2. And once patient improves, then definitely we can think of doing decalibration in this situation, keeping a moderate ventilator setting. Prone positioning, it can help to reduce the collapse of the dorsal lung segment with subsequent avoidance of the alveolar distension. In patients with the severe ARDS, prone positioning has been proven to be beneficial by improving the oxygenation, and indication includes the difficult to wean severe hypoxemic patient and the injurious ventilator settings, and those patients who are uh, not maintaining their saturation on ECMO. But we should always remember that doing a proning during an ECMO may be quite challenging and risky, especially if the patient is more actively stable and there is always a risk of disconnection or decap. Recruitment maneuver, again, it's an indispensable component during as a lung protective ventilation, because you are going to recruit those alveoli which are not taking gases. So various approaches has been tried, increasing the PEEP or open lung approach, but during ECMO, it has not been studied. But still, we are keeping a high PEEP during the ECMO run to keep these alveoli open. In the early phase of ARDS, we do not recommend to use the spontaneous breathing because it can lead to a self-inflicted lung injury. But we should keep in mind that the prolonged deep sedation and paralysis um, associated with the poor outcome, which may lead to ICU-acquired weakness or ventilator development of ventilator-associated pneumonia. But we should make a good balance between the deep sedation paralysis, especially in the early phase for the first 3 to 4 days, and then you can start using the paralytic agent and you can start using the sedation once patient understands and patient is breathing comfortably. Use of ECMO in awake patient is getting more and more popular, um, but we have to do it on the individualized basis. So let's see on the ventilation during a VA. When we talk about the VV ECMO, we were talking about the limiting the alveolar restraint, because we want to prevent the lung injury by restricting our peak plateau inspirated pressure around 25. But what happens in the VA ECMO? Let's see what goal we want to achieve actually during the VA ECMO. We are already allowing lung rest or minimal ventilation VA ECMO, which may result into the hypoxia because there is a coronary perfusion may not get adequate oxygen. So there is a risk of myocardial ischemia. So we have to ensure that adequate oxygen is going, because the coronary and cerebral circulation is being done by the left ventricular ejection. So to prevent any hypoxia or in the coronaries or cerebral perfusion, we should not go for this. So it is not mandatory to restrict your pressure to 25. You should ensure adequate uh, oxygenation in your patient who is on VVA. So let's look at the atelector trauma, which we restrict by maintaining a higher level. So what is happening with the high heat? We are reducing the venous return, reducing the cardiac output, already compromised patient who is hemodynamically unstable, and for that we have placed this patient on VA. So this can lead to increased pulmonary vascular resistance and increase the right ventricular overload, and there will be a reduced left ventricular compliance. So you don't need to keep a high PEEP during a VA ECMO. However, it should be individualized. If the patient has concomitant ARDS, then definitely a high PEEP will be indicated if patient is maintaining hemodynamics. But a routine use of high PEEP is usually not required. The third, we try to limit the reabsorption by decreasing the ventilator FiO2 and maintaining a high level PEEP. So we know that in mechanically ventilated patient with acute lung injury, breathing pure oxygen leads to a de-recruitment, which is prevented by the high. However, intraoperative high inspired oxygen fraction decreases the risk of surgical site infection. Surgical patient who was receiving the prophylactic antibiotic has a weak effect on the nausea and does not increase the risk of post-operative atelectasis. So again, the VBA ECMO is not going for a very long time, 5, 6 days, 7 days, or 8 days. So again, this strategy may not be very useful. So your target should be maintaining adequate oxygenation to ensure adequate oxygenation in the upper body whenever you are putting the patient on VA. So should we continue the normal ventilation? Yes, we can target a lower tidal volume, not as a normal one. We can keep around 6-7 per kg so that this can decrease the incidence of adverse outcome. And we adjust the P as per the cardiac function and existing lung function. So, because we can understand there's a relatively low flow through the pulmonary vascular system. So what is going to happen? There will be localized pulmonary hypocapnia and there can be alkalosis. That also we should keep in mind. Because arterial blood gas measurements are not normally telling you about the pulmonary function for a patient who's on VA ECMO. So you should be careful that from where you are obtaining your ABGs, probably that is very, very important. For example, when you are taking your ABG or oxygen saturation from the right arm or right radial artery in cases of femoral. So adequate ventilation, what should be your adequate ventilation on VA ECMO? There should be sufficient myocardial and cerebral oxygenation. There should be less risk of atelectasis. And you can wean your patient on VA ECMO, probably that will be the best start. So adequate FiO2, how you ensures that you are giving a sufficient oxygenation and you are reducing the pulmonary vascular resistance. So you are not making or you are avoiding any RVR. But you cannot say that which one is the ideal mode. You can individualize as per the patient and as per as your unit protocol and your experience. A word about the role of adjuncts. Prone positioning, we have already discussed that most of the studies in the form of cohort studies are, but it has shown the beneficial effect, especially in improving the oxygenation. Inhaled nitric oxide, the evidences are almost most of the places, the evidences are very weak strength evidences that except for the RV dysfunction, possibly there is no role of giving an inhaled nitric oxide. Again, steroids. It may improve the lung compliance in patients who are on ECMO, but definitely the complications associated with the use of steroid is there is always a risk. Neuromuscular blockade, reasonable use in the initial phases, but there is always a risk of critical illness, myopathy, and death. Surfactant, especially in the neonate, yes, there is a blind randomized trial which has shown an improved survival in the neonate by use of surfactant during an ECMO run. Airway clearance, routine use of bronchoscopies in these patients is only restricted to the case reports and cohort studies. But yes, if the patient is having secretions, patient is having a airways blockage, so in those conditions, definitely bronchoscopy should be done to clear the secretions as well as remove the debris from the lungs so that you can improve the gas exchange and improve the tidal volume. So to conclude, the primary goal of mechanical ventilation in patients who are on ECMO should be optimization of the respiratory variable to permit healing from the pathologist. So basic in the VB ECMO, we are putting these patients on ECMO because of preventing the lung injury, and that should be on. You should keep in mind that there is a hemodynamic effect of the mechanical ventilation who are on ECMO. We must remember the physiological difference between the VA ECMO and VB ECMO while adjusting the mechanical ventilation. It is important to consider the possibility that patient on ECMO may not require invasive ventilator at all. So if at any point of time you feel that your patient does not require ventilation, you should always wean your patient and extubate these patients. Most of the data used to establish the guideline for a mechanical ventilatory strategies in ECMO patients derived from the study who are associated with the AID. So this is the ECMO acceptable range and ELSO acceptable range and ELSO recommended range that your plateau pressure should be less than 30. If possible, it is always better to be less than 25. They have not recommended for the tidal volume, but they recommend that use of the pressure modes are good. PEEP should be more than 10, and FiO2 as low as possible to maintain the adequate saturation, which is not compromising your tissue lactates and metabolic acidosis. The frequency should be lower, should be ranging from 4 to 15. It is recommended. So around 10 is a good strategy to keep the ventilatory rate to prevent the lung. Thank you very much. I'll be happy to answer if there's